So my patient responded quite well, tolerated the drug very well, and continued to show a response at subsequent scans after the first restaging scan had been performed at 3 months. Unfortunately, we saw isolated progression at 18 months. I would say this is not surprising. We have seen on clinical trials that the progression-free survival on osimertinib is about 18.2 months, and this patient's progression happened right around that time. So I'm not surprised that this happened. So at the time of an isolated progression, I usually would rebiopsy to confirm that the histology is intact the same. In fact, at the time of progression, I often rebiopsy to confirm progression and also to determine what the histology is at the time of the progressing event. I usually proceed with restaging scans in the form of CT scans of the chest, abdomen, and pelvis, as well as an MRI of the brain, and then proceed based on the results. So we have made a lot of progress to date in the treatment of non-small cell lung cancer, especially for patients with EGFR-mutant disease. We are routinely looking for these mutations. We now have better drugs that can provide superior survival outcomes with better penetration into the brain. I would say that there are still areas that we can do better in, one of which is the use of plasma-based NGS, not just at diagnosis, but also to follow patients and to really identify patients who may not be deriving the full benefit from frontline therapy. Additional areas of research include treatment at the time of progression, what to do once osimertinib stops working. We now know that MET amplification is the mechanism for majority of the patients that progress on osimertinib, and clinical trials are underway to evaluate drugs that may target that amplification. So much more to come, and this is an exciting time.